Hello, everyone. My name is Sarah Kalia. I am a contract genetic counselor with Genome Medical and a PhD student in population health sciences at the Harvard School of Public Health. The topic I'll be talking about today is secondary findings in clinical practice. Our goals are to define secondary findings in the context of genomic testing, identify criteria for the ACMG minimum list and the main categories of genes and conditions on the list, describe the ethical challenges related to genomic secondary findings, and explain how the potential for secondary findings may impact pre- and post-test counseling for genomic testing. We'll start with a few case examples and then talk about the background and guiding principles that guided development of the ACMG recommended list of secondary findings. We'll talk about that list and we'll move into discussing ethical considerations and implications for clinical practice. So secondary findings, which are also often called incidental findings, are findings that are unrelated to the primary reason for genetic testing that may provide information about a genetic risk which may not have been suspected based on the medical or family history. I'm going to start with a few examples of secondary findings from exome sequencing. And these cases are from the BabySeq project, which was a randomized controlled trial at Brigham and Women's Hospital and Boston Children's Hospital that randomized healthy and sick newborns to receive either standard newborn screening or standard newborn screening plus exome sequencing. In this first case, the proband is a male infant with hypoplastic left heart syndrome who was randomized to receive exome sequencing, and this is the family history that was taken pre-test. On exome sequencing, a genetic result was uncovered that was completely unrelated to his heart condition. He was found to have a BRCA2 pathogenic variant. If you look here at the family history that was taken pre-test, the BRCA2 pathogenic variant appears to be an unanticipated finding. This is the same pedigree, but with additional information collected after results disclosure, with targeted questions that asked about BRCA2 related cancers. It turns out there was a maternal family history of ovarian cancer, breast cancer, and pancreatic cancer, all of which are associated with BRCA2 pathogenic variants. And this demonstrates the importance of gathering a comprehensive family history. It also shows that genomic findings that initially seem unexpected may lead to disclosure of relevant medical and family history that was not previously discussed. This is a different family in which a BRCA2 pathogenic variant was also found, this time in a healthy infant proband, and was determined to be maternally inherited. There is a family history of breast cancer. So although the mother was previously unaware that there was a BRCA2 pathogenic variant in the family, she had already been receiving increased breast screening because of the family history. In this family, an MSH2 pathogenic variant associated with Lynch syndrome was found in a healthy infant proband, and it was determined to be maternally inherited. The family history was not very suspicious for Lynch syndrome, but the mother is over 40. She had never had a colonoscopy or screening, and so she's now being followed in a hereditary cancer clinic. These days, there are standards for how to approach the analysis, reporting, and counseling for secondary findings from clinical genome and exome sequencing. I'll talk now about how those approaches came to exist. So in the fall of 2011, clinical exomes became available, and labs and clinicians were unsure how to handle the reporting of medically important findings that were discovered through sequencing, but were unrelated to the reason for testing. There was no general consensus in the field about what approach to take. In 2012, Robert Green of Brigham and Women's Hospital led a survey of 16 clinical and molecular genetics specialists. Each was given a list of 99 genes that were commonly ordered for clinical testing and asked, for which of these genes should a variant be reported back to the ordering clinician if it's discovered incidentally through genome sequencing? And does it matter if the patient's an adult versus a child? Additionally, does your answer change if the variant is known to be pathogenic versus presumed to cause disease versus predicted to be disease-causing without empirical data about that variant? The results showed that for several of these 99 conditions, there was a lack of consensus about whether or not to return incidental or secondary genetic findings. There was more consensus about returning a result if it was a known mutation, and less consensus if the variant was only predicted to be disease-causing. There was more agreement around returning unanticipated genetic results on adult patients, but less agreement about returning secondary findings found in children. So with these survey data showing a lack of consensus, even among genetics specialists, the Board of Directors of the American College of Medical Genetics and Genomics, or ACMG, established a secondary findings working group, which was co-led by Robert Green and Les Biesecker. The working group's charge was to describe the principles and approaches to guide search and reporting of secondary findings from clinical whole exome or genome sequencing, decide if there should be a list of genes or variants to be sought, interpreted, and reported back to the ordering clinician. If yes, then define that list or develop a process for generating the list. Decide if there should be a mechanism for declining or opting out of the interpretation or return of some or all secondary findings. And decide if there should be recommendations to the ordering clinician that should accompany secondary findings. The working group's efforts resulted in this 2013 publication, which included a minimum list of 56 genes associated with 24 conditions that were recommended to be analyzed and reported back to the ordering clinician in all cases where clinical exome or genome sequencing was ordered for a specific indication. Many of you may be familiar with this list, which was originally often called the ACMG 56 and now often referred to as the ACMG 59. The genes on the original ACMG 56 were selected because they met certain criteria. Most of these genes were inherited in an autosomal dominant fashion. At the time, it was advised that known pathogenic and expected pathogenic variants in most of these genes were appropriate for return as secondary findings. KP and EP are the older nomenclature before publication of the 2015 Richards et al. Guidelines for Variant Interpretation. These categories translate approximately into pathogenic and likely pathogenic using current terminology. The genes included on the ACMG minimum list had relatively high penetrance. They were associated with diseases with a long asymptomatic period, so high likelihood of catching a risk that had not yet manifested as disease. And these were actionable genes, so there was some type of screening or surveillance that would be offered to individuals with this known genetic risk and potentially prophylactic measures such as surgery. The 56 genes and 24 conditions on the list were primarily related to increased risks of cancers, cardiac disorders, and adverse reaction to certain types of anesthesia. And this was a minimum list, so labs could choose to also offer analysis of additional genes or conditions if they chose to do that. A few categories of conditions that were not included: neurological or neuromuscular diseases were not included because in most cases there's no intervention for these diseases. Many are caused by repeat expansions, and with current sequencing technologies, there's a limited ability to reliably detect these types of variants. Some also have low penetrance, like the ApoE4 risk variant associated with late onset Alzheimer's disease. Mitochondrial disorders were not included because the presentation is extremely variable and in some cases may be mild. Inherited thrombophilia variants were not included because they may have low positive predictive value. In other words, among those who are found to have a risk variant, there's a low chance of actually having the phenotype. The secondary findings recommendations generated a lot of dialogue and some controversy in the genetics community. So later that year, the ACMG Board of Directors published a clarification statement that covered key topics in the original recommendations. These topics included the rationale for not including an opt-out, and that was because there was strong evidence of pathogenicity and actionability for all genes on the list. Additionally, the ACMG recommendations stated that the clinician and the patient could ultimately decide together what secondary findings the patient would learn and when. The list includes many adult onset conditions, and the list applied to children as well as adults. And that's because that learning genetic risk through secondary findings is different than screening or diagnostic testing for a known genetic risk. Secondary finding is by definition unexpected and therefore might not be learned another way. The clarification statement indicated that labs were not expected to modify their existing pipeline for detecting secondary findings if it wasn't optimized for those secondary findings at this time. But labs should state the limitations of their secondary findings analysis pipeline clearly on the lab report. Additionally, the clarification statement emphasized that results returned should be led by a genetic specialist if possible, or by the referring clinician. A few months later, the journal Genetics in Medicine published results of a survey of ACMG members, including medical geneticists, lab geneticists, and genetic counselors. The survey asked for members' opinions about key points in the ACMG recommendations. More than 80% of survey respondents supported the option for patients to opt out of receiving incidental findings or secondary findings. More than 90% supported the idea of a minimum list of genes that labs would offer to analyze for all patients having genome sequencing. And opinions differed on whether to return this information when found in a child. In late 2014, the ACMG Board of Directors published an updated policy statement about secondary findings. In it, they emphasized key elements of informed consent. They changed the recommendations to allow patients to opt out of receiving secondary findings, but recommended against allowing each patient to specifically choose which of the ACMG 56 genes they wanted analyzed. The choices should be to have all of those 56 genes analyzed, or none, or potentially additional tiers if the lab chose to offer that. And this recommendation held for all patients, regardless of their age, including children. The ACMG board also recognized that the minimum list of secondary findings genes would need to be updated over time as the field learns more about gene disease associations. So they assembled a secondary findings maintenance work group chaired by Krista Martin and David Miller to develop and maintain a process for updating the minimum list. This is the process that the working group developed. They created a nomination form for nominating genes or conditions to add or remove from the list, accepted nomination forms from ACMG members. Each form summarizing the evidence for that gene and condition was presented to the secondary findings maintenance working group by the person who submitted the nomination form or someone that they designated. And then the working group discussed that gene or condition and voted on the proposed change. Any motions that were approved by the working group then had to also be approved by the ACMG Board of Directors. The criteria for adding or removing a gene from the secondary findings minimum list are related to some of the same criteria that were used to assemble the original list. So it's based on the clinical features of the associated disease, the likelihood that a primary care physician would be able to diagnose the disease early in the disease course, even without knowing about the genetic risk, molecular genetic features of the gene, and clinical genetic testing options. In other words, the potential for patients to have genetic testing for this gene independent of the secondary findings analysis. And a critical criterion was medical actionability, which is comprised of the severity of the disease, the nature of the health threat, penetrance, in other words, the likelihood that symptoms would manifest, the efficacy of interventions for the disease, overall, how much we know about the gene and condition, and how acceptable the intervention for the disease would be based on the risks and the benefits of intervening. One resource that is helpful in evaluating genes for potential addition to the minimum list is the work of the ClinGen Actionability Working Group. ClinGen is the clinical genome resource. It's an NIH-funded effort to aggregate information about relationships between genes and disease phenotypes. And the ClinGen Actionability Work Group, which is led by Jim Evans and Katrina Goddard, they're tasked with reviewing the evidence for gene-disease pairs and scoring each pair based on its medical actionability. The ClinGen actionability criteria are shown here and include severity of the disease, a penetrance estimate and how much evidence exists to support the estimate, how effective is the medical intervention for that disease, and how much evidence exists to support this, and how risky is the medical intervention. So in September of 2016, the Secondary Findings Maintenance Working Group published an update to the secondary findings recommendations in the journal Genetics and Medicine. The updated recommendations upheld the core tenets of the original ACMG recommendations, namely the concept of a minimum list of genes offered to be analyzed for secondary findings in all patients undergoing clinical sequencing. In response to the nominations that were received from the ACMG community, 4 genes, BMPR1A and SMAD4 associated with juvenile polyposis, ATP7B associated with Wilson disease, and OTC associated with ornithine transcarbamylase deficiency were approved for addition to the minimum list. And 1 gene, MYLK, associated with familial thoracic aortic aneurysm and dissection, was removed from the list after additional review of the evidence concluded that there was insufficient evidence to support keeping it on the list. The list in its current version is the ACMG Secondary Findings List version 2.0. It's often called the ACMG 59, but the reason for avoiding that terminology is that future versions of the list could include a different set of 59 genes, so referring to the list by version number can avoid ambiguity. Moving forward, major conceptual changes to the ACMG recommendations will be accompanied by a new version number, like version 3 or version 4, and minor changes would be denoted by version 2.1, 2.2, etc. Future areas of focus for the Secondary Findings Maintenance Working Group include expanding the nomination process to other professional organizations. So currently nominations are only solicited from ACMG members, but that may be expanded to other organizations. Pharmacogenomic variants will continue to be considered for the minimum list. There are a few unique aspects of pharmacogenomic variants. There can be challenges in calling these variants from sequencing, and pharmacogenomic variants may be tested separately in clinical care before a physician prescribes a drug that has a known pharmacogenomic association. Also, use of certain of these drugs is quite rare. There have been and continue to be efforts to address the medical, behavioral, legal, social, and economic impacts of secondary findings in different populations, including the impacts among clinicians, patients, and their relatives. And there are ongoing efforts to meet the increased genetic counseling needs for patients who receive secondary findings and their relatives who could benefit from cascade testing. Ethical considerations are important factors in determining how to handle secondary findings in clinical care. This Bioethics Commission report on the ethical management of incidental findings and secondary findings was published in December of 2013. At that time, the ACMG recommendations did not include an opt-out option. And this report was published just before ACMG members were surveyed about their opinions on the ACMG recommendations. So this Bioethics Commission report may have influenced some survey responses. The ethical principles addressed in this report related to secondary findings included respect for persons or autonomy. The opt-out option addresses this now because patients can choose whether or not to receive secondary findings. Beneficence or doing good. So to ensure that patients benefit from learning of secondary findings, there needs to be high standards for clinical validity and medical utility of the genes on the list, and also results disclosure by a knowledgeable genetics professional. Justice and fairness. So there should be equal access to actionable secondary findings among all patients who have clinical genome or exome sequencing. And intellectual freedom and responsibility. So patients have the responsibility to make an informed choice about whether or not to opt into secondary findings, and the pretest informed consent process helps to enable this. The second controversial element, the fact that the minimum list includes some adult onset conditions, but these are recommended for return to any patient, including children. So in this case, there's an ethical tension between autonomy of the child versus beneficence. The child doesn't get the chance to decide whether he or she wants to learn of secondary findings. That decision's made by the parents. However, there's the potential that knowing of the genetic risk could benefit the child and more imminently could benefit one of the parents from whom that risk variant was inherited. For families without a known family history of the disease, the parent may be unaware of that increased risk. And early knowledge and screening could improve the parent's prognosis, even save his or her life, which could indirectly benefit the child from having their parent around longer. One challenge that we will continue to face is how to notify children of secondary findings at an appropriate age. We also need to consider the psychosocial impact of learning about an adult onset genetic risk at a young age, including what's the impact of growing up with knowing about that risk. Again, how do we address the child's autonomy and right to decide whether to learn that information? And we also need to think about these secondary findings recommendations pertain to individuals who are having clinical sequencing for a specific indication. And so it's important to think about whether the diagnostic odyssey that parents may have gone through may make it challenging for them to evaluate the impact of secondary findings found in their children. Now, tying together the historical context, the ACMG recommendations, and ethical considerations, let's consider what are the implications for genetic counselors' clinical practice. In a media statement shortly after the ACMG recommendations were originally published, NSG responded to those recommendations. The key points touched on informed consent as well as contextualization of results by a genetics expert. So some excerpts from the statement were, when these incidental findings relate to a serious, well-characterized medical risk with implications for clinical care, laboratories should identify and disclose them to clinicians as a part of the return of results process. Pre-test counseling should provide patients with clear expectations about what the test can and cannot provide. Physicians using genomic testing should be prepared to help patients access a professional with specific genetics training, such as a genetic counselor, who can help them put the results into context and develop a plan for follow-up. On the topic of informed consent, approximately 6 months after the original ACMG recommendations were published, the ACMG Board of Directors also published a points to consider document with elements to include in informed consent for genome or exome sequencing. The Bioethics Commission's report on secondary findings also made a recommendation related to informed consent. And it stated, clinicians, researchers, and direct-to-consumer providers should describe to potential recipients incidental and secondary findings that are likely to arise or be sought from the tests and procedures conducted. Practitioners should inform potential recipients about their plan for disclosing and managing incidental and secondary findings, including what findings will and will not be returned. In 2017, an article by Fowler et al. In the journal Genetic Counseling reviewed consent forms from 18 genetic testing laboratories to determine which of the consent topics recommended by ACMG and recommended by the Bioethics Commission report were included in the lab's consent forms for clinical exome sequencing. The recommended consent form elements are shown here and include a description of exome sequencing, the purpose of exome sequencing, the benefits and risks, potential uncertainty of the results, follow-up if results are updated, to whom would results be returned, describe the results returned to the proband, describe what results would be excluded from the report, define secondary findings, present options for the ACMG minimum list results, discuss return of secondary findings for minors, and disclosure of secondary findings to relatives, disclosure of carrier status for recessive disorders, the fact that the sample may be shared in databases, and the request to use the sample for research, who has access to sequence data, the opportunity and option for genetic counseling, and the potential risk of discovering misattributed parentage. This graph shows the percentage of the 18 consent forms that included each of those elements. The gray bars are showing among all labs what percentage included each of these elements. The orange bars show only academic labs, and the blue bars show commercial labs. So when you're thinking about how to integrate secondary findings, consent, and disclosure into your clinic routine, there are a few steps to consider. These are really very similar to what you would do for any clinical encounter that involves genetic testing. You want to investigate different lab options, and note that some labs offer additional tiers of secondary findings that the patient can opt into, in addition to the ACMG minimum list. You want to choose the test in the lab based on the patient's unique clinical situation and preferences. Provide pre-test counseling about potential results, including potential secondary findings, with the categories of conditions that might be found and specific examples. Provide post-test counseling about the actual results that are discovered, and then follow up and make referrals as appropriate. In some cases, you may need to acknowledge a specific patient situation. So for example, for a critically ill or pediatric patient, learning of a secondary finding immediately may not be the most pressing issue. You may need to think about who may benefit the most from learning secondary findings, or who's the most critical person to learn that information. For example, the mother of a child who is found to have a BRCA mutation, if that mutation is determined to be maternally inherited, it may have most imminent implications for the mother. Consider that most conditions on the list can have pediatric onset, so may have relevance for children. And again, consider that learning of a secondary finding in a child may diagnose or predict genetic disease in the parent from whom that variant was inherited. When it's time for disclosure of secondary findings, if a secondary finding comes back on the exome or genome results report, first confirm the patient still wants to receive secondary findings, even if they already consented to receive this information. Sometimes their decisions may be different when it's hypothetical versus an actual result, or their preferences may have changed for other reasons. You may need to be flexible and adjust the plan based on the current reality. So are there diagnostic results that are identified that really need to be the patient's focus in the immediate short term? Respond to patients' needs and immediate concerns, and plan for future disclosure of secondary findings or additional follow-up to discuss that information again if the patient doesn't have the ability to focus on secondary findings in the initial disclosure. Of course, you want to understand the clinical implications of the secondary finding, and that may necessitate a reevaluation of the patient's medical and family history in the light of the secondary findings with targeted questions looking for manifestations of the associated disorder. When it comes to interpreting negative results, and that includes a lack of discovery of secondary findings, discussion should include the technical limitations of genome and exome sequencing and the potential inability to reliably detect certain types of variants. The fact that sequencing is not as comprehensive as targeted genetic testing, and many variants do not have sufficient evidence to be classified as pathogenic or likely pathogenic, especially among minority populations. So a genetic risk may still exist, and at minimum, the patient still has the general population risk for these diseases. Want to distinguish between a risk factor versus a diagnosis. In most cases, with a secondary finding from the list, the patient would be learning about a risk, not a diagnosis. You may want to consider confirmatory testing for the secondary finding, and this is something that may be good to discuss with the lab before disclosing the results to the patient to understand the lab's methodology that they use to detect and confirm secondary findings. You want to document the actions you take based on secondary findings and the rationale for those actions. Plan for follow-up evaluations as appropriate, depending on the genetic risk that's identified. Make referrals to other specialists as appropriate, and talk with the parent about sharing this results with relatives, because cascade testing of at-risk relatives may also be important. There are still unresolved questions about management of secondary findings. There's a lack of empirical data about the pathogenicity of these variants in an unselected population and in certain ethnic groups. There's also some incorrect information in public databases about the pathogenicity of specific variants. Data storage in the electronic medical record can be an issue if the ordering clinician and the patient decide not to disclose all secondary findings to the patient immediately due to the patient's unique clinical situation. In that case, we would want to avoid having other clinicians who have access to the report accidentally disclosing that information to the patient without understanding the results or without knowing that there was a decision by the patient to delay learning those results. And post-mortem disclosure of secondary findings to relatives. This can be important when the secondary finding has medical importance to at-risk relatives. So when incidental findings are available for a deceased patient, HIPAA regulations do allow disclosure of the deceased patient's clinical results to a healthcare provider if it's for the purposes of treating a relative of the deceased individual. But if those results are not directly applicable to a relative's clinical care, then disclosure of relatives is only allowed if the deceased patient or their legal representative previously signed an authorization form. So particularly when the primary reason for genome or exome sequencing is related to a life-threatening condition, it's important to work with the patient and the family through these considerations during the consent process, acknowledging that there is the potential that a secondary finding could come up and these issues of sharing with relatives could become relevant. I hope that this talk has been helpful in addressing these learning objectives. And I hope this background and context is helpful when you encounter secondary findings in clinic or in the lab or research. And I encourage you to spend some time considering how this information will shape how you counsel patients prior to testing and when a secondary finding is discovered. I hope you'll consider how you'll help patients understand the types of results they might receive and how secondary findings do or do not fit in with their motivations for testing. If you have any comments or questions, you're welcome to reach out to me. My email address is shown here at the bottom of the screen. Thank you.